Hello, everyone. Thank you so much for joining me today. My name is Kimi Landry, and I'm from the Center for Improving Value in Healthcare, or CIVHC. I'm sure many of you have seen us before at this conference and many other times. But today I'm really happy to share what we've learned from a project we completed with the Denver Indian Center, where we were looking at health patterns among American Indian and Alaskan Native residents in Colorado. This analysis used 10 years of data from the Colorado All Payers Claims database. So, why does this work matter? We know that Native American communities in Colorado continue to face big, long-standing gaps in health and access to care. Emergency room visits are still high, but follow-up care, those crucial next steps after someone leaves the hospital, happens less than 5% of the time. That number has barely changed in pretty much a decade. So behind those numbers, though, are real people, families managing chronic illness, likely traveling long distances for care, and often navigating systems that weren't built for their realities in mind. So this project was really about using data we do have to see those stories more clearly and hopefully start to close the gaps in health outcomes. So for our data and methods, we looked at 10 years of APCD information from 2014 through 2024. To add context, we linked it with population data from the American Community Survey and used what we call Z codes, which are basically billing codes that describe social or environmental stressors like housing or employment challenges. And altogether, that gave us a picture of about 5.6 million Coloradans. And we really focused on comparing American Indian, Alaskan Native populations to non-Hispanic, white, and unknown race groups. So our first takeaway was around preventative care. You'll see from this slide that American Indian, Alaskan Native residents had fewer preventive visits and screenings documented, but higher rates of chronic illnesses, things like diabetes and thyroid disorders. This to me really suggests, and to Denver Indian Center, that people are reaching care later when problems have already progressed. We also saw fewer recorded mental health diagnoses. Again, that doesn't mean less need. It's more likely underdiagnosed, possible stigma happening, or simply that mental health care often happens in settings that don't bill through insurance and therefore don't appear in these data. So next we looked at how care is being used. Hospital stays declined by about 10% over the decade, which could mean better access to outpatient care, but emergency visits stayed high. And when people did go to the hospital or ER, we saw that very few had follow-up appointments afterward. That's where claims data can be very revealing, and I think are very revealing here. We can literally see the start of an encounter, but often the continuity of care that should follow is not being seen here. So when we turned or looked at costs, we found that spending for American Indian and Alaskan Native residents averaged around $1,000 per person per month, and higher for those covered by Medicaid. Commercially insured members spent less overall, excuse me, but their patterns were still different from other racial and ethnic groups. And really the key takeaway here isn't about dollar amounts. It's about cost and coverage. It's about how cost and coverage don't automatically translate into what seems to be equitable access or outcomes. Geography tells also another important part of the story. As you can see from this slide and this map, most care happens in Denver and Aurora, often through safety net systems like Denver Health. Pueblo saw declines, while I apologize, I am not great at pronouncing this, near the Mountain Ute tribe saw increases. And then that pattern reinforces what community patterns have been saying for years. And what the Denver Indian Center really helped reinforce for us is that people go where they feel welcome and where relationships with providers already exist. So finally, we explored social risk data. We can see from this slide that housing instability, family strain, and work challenges through Z codes. But we know that this often underrepresents reality. Z codes are very limiting in terms of billing and administrative structure. When we compared it to census data, it was clear that claims only show a small slice of what people are actually experiencing. And one of the biggest lessons from this project, even our best data sets still miss a lot of lived experiences. So combining them is really important. Claims are great for showing where care happens, but not necessarily why it happens or what's missing in between. So some implications and next steps. First, we have to keep improving how race and ethnicity are collected in administrative data. That is foundational. Second, we need to help providers and systems understand the importance of culturally grounded care, not just more care. And third, we need to keep working directly with Native American and Alaskan Native-led organizations. So analyses and evaluations like this are guided by community priorities, not just research questions. At Civic, our role is to make sure data is used as a bridge, something that connects systems to the people they're meant to serve. These are some references to today's presentation. And then, yeah, thank you for listening. And I want to give a special thanks to our partners at the Denver Indian Center and to the communities whose data and experiences made this work really possible. So thank you again for joining me and listening to my presentation, and looking forward to taking questions.